use mini dental implants for permanent restorations? How many say yes? How many say no? You're going to hear all sorts of comments from clinicians. You're going to hear that they're not FDA approved. You're going to hear mini dental implants are temporary implants. Let's break some of those myths. We have 510Ks. They are FDA approved. These devices will permit immediate splinting, stability, and long-term fixation for new existing crowns and bridge installation for full partial edentulation, employing minimally invasive surgical intervention. And the other one says, the abutments have been designed to be used in either mandible or maxilla to support removable or fixed prosthetics. So mini dental implants are FDA approved. Let's look at some studies. What do the studies show? Dr. Shatkin up in Buffalo is probably the most prolific placer of mini dental implants, and his late father and him have been doing this for at least 15 years. And his father was an oral surgeon. He took a look back over 5 years at 2,500 implants that he placed, mini dental implants, and their success rate, 94.2%. Some other studies by Ahn, Mazer, and Bullard, all above 90% success rate with mini dental implants. So the literature is clear of this. It's a viable option. But for whatever reason, it's not being utilized, or not as much. Let's take a look at this case. Actually, this is one of my favorite cases. This young lady did not have her 2 front teeth since 1999. Walking around with a flipper. Very embarrassing. She's got about 4.5 millimeter of buccal, lingual bone. So what can we do? What are our options? What's normally taught is to flap. Try to place a 4 millimeter implant. Obviously, you're going to destroy the buccal bone, so you're going to have to graft. Wait 6 months, and then restore. That's what we've been taught. That's what I've been taught. That's what I used to do. Not anymore. It's too aggressive, too invasive. It's just not necessary. When you place mini implants, the implant does the drilling itself. We're removing almost no bone. We're actually compressing the bone, making it more dense and stronger. We're taking bone that may be class 2 or class 3 and turning it into class 1. My drill, which is a 1.8 millimeter drill, only goes up about 8 millimeters, just to create a pathway for the implant. The implant does the rest of the work. The implant, this is a 3 millimeter implant, compresses the bone and does the job by itself. So we place 2 of these. You can see the gingiva has not been disrupted. The architecture remains the same. We could take a mold today and have the crowns ready in just a couple of weeks. This is how she leaves. She was almost crying. She couldn't believe. She couldn't believe it. 12 years with no teeth. And the reason why she couldn't get it done, because it's too expensive. It was too expensive to do it the traditional way. To do almost a year of treatment with the bone grafting and the implants, and the clinician's time, which will take hours, gets to be very expensive. This is affordable. It was affordable for her. And this took maybe 45-minute appointment to do all this, and then a visit after that is 5 minutes to cement it in. We're cutting down clinical time, making the procedures easier for the patients, easier for the doctor, more affordable. Implants are not for the elite anymore. Now people can afford this treatment. And that's the final. And she couldn't be happier. She was almost crying. What can we do here? Here you really have no choice except to do mini implants. Or you can do a bridge. I would not trust these teeth to do a bridge. Obviously, she has some perio issues. Even though we cleaned her up, there is a recession, and these teeth are not going to last forever. Place 2.5 millimeter dental implants. Gingiva looks extremely healthy. That's the final result. Now, getting back to one of my first slides about having a good dental lab, I don't take the shade. I cannot do a good job if I take the shade. I have a great laboratory, and the patients will go to my laboratory. That's one of the advantages of being in the city. I have dozens of laboratories in 2-block radius. So I pick the best lab, have the patient go there, have the master lab technician match up the shape. You can't see which one's an implant. And if there is an issue, we're not going to start sending cases back and forth and waiting a week. The patient will go to the lab, get a little custom staining, and they'll still get the crowns the same exact day. And if we looked up and look at the gingiva, that's how it looks like. Case, we have number 24. It's a baby tooth, and he would like a permanent tooth. The baby tooth comes out, implant goes in same day. You can see how healthy the gingiva looks like. It has not been disrupted. There's not going to be any bone loss at all. We have non-interrupted blood supply. The surgery was not invasive or least invasive. That's the final. And that's the lab technician, that's art. What they did is art. That's perfect. You can never tell that this is an implant. Okay, let's just do a case step by step. So I want to show you how easy it is. This is done routinely in my office. At least, I would say a couple times a week at least, sometimes more. So this patient would like implant number 13 to replace a missing tooth. We have a temporary ready to go. The temporary is worth every penny. Not only is it the patient is going to leave with it and smile with it, but also this is your surgical guide. This will tell me that I'm putting the implant in the right place. It's also going to give me a preview and the patient a preview of what to expect later. So that there's no, well, I want my tooth to look a little bit different. Or my teeth used to look like this, how come this looks like this? If the patient doesn't like it, they'll tell me right away. And on the final, we'll make the adjustments. So we create a surgical guide. We want to place the implant in the cingulum, a little bit towards the working cusp. You got plenty of bone. You can place, I'm placing a 3 millimeter implant. In reality, you can probably place a 4 millimeter implant, and that's fine. But why would we? We look at Tano's rule, the 1.5 millimeter buccal plate, where he did the study, the famous study, and he says on average, if you have less than 1.5 millimeter buccal plate, you will get recession. But that's an average, and we're all different. So why not leave 2 millimeters, or 2.5 millimeters buccal plate? Why not play it safe? So that in 7 years, there's still no recession. The implant's not going to break. The implant's not going anywhere. In fact, it's stronger than a conventional implant. This is a one-piece implant. There is no tiny screw holding the two components together. It's a solid one-piece implant. And I like the one-piece implant. It allows me to keep it simple. The more pieces you have, the more components you have, the more complications you can run into, like screw breakage and screw loosening. These I avoid completely by using a one-piece implant. There's my drill, creating a pathway. There's the implant. I have bicortical stabilization. It's touching the cortical bone of the sinus a little bit. It's also touching cortical bone towards the chrome. There's my implant around the single area. There's the implant with a healthy gingiva and plenty of buccal bone around it. There's my surgical guide that's now been relined and now is my temporary. Patient leaves with a temporary, and here we have the final crown. 2 weeks of treatment, less than 45 minutes, chair time. Why not? Similar situation, lower implant. There's the implant, there's the temporary, there's the final. Okay? We also decided to replace that as well. Can we split teeth to implants? How many say yes? We can split teeth to implants. How many say no? Okay, a lot of no's, a lot of no's. Let's take a look at the literature. I know it's hard to see, but this is a critical review of literature by Dr. Tino and his team of Cavallero, Greenstein, and Smith. And they took a look at about 30 articles and looked back at the success rate of splitting teeth to implants. I know it's hard to see. But most of the studies show, all except one. There's one study by Bragger over 22 patients that has a 68% success rate. Other than that, every single study shows the same success rate. And even Bragger did another study that shows a 95% success rate, splitting teeth to implants. So the first one was 100%, 95%, 100%, 98.7%, 93%, 95% success rate. And this is over a several year period. So why is the myth out there? That's what I'm wondering. The literature is very clear that if it's a healthy tooth, it's a healthy implant, you should not have it. This patient presents to us, he says, he's terrified of the dentist, as you can tell, he's terrified. He says, I don't want any extractions. Don't extract any of my teeth, can you fix me? I would say, sure. We just need a little more support here, and we can make him a roundhouse bridge. Place 2 small implants, just to give you that extra support. We prep and press implant same day. He leaves with a temporary, already looking a lot better than when he came in. This is all one visit. Framework trying 2 weeks later. He's finished. About a month. Okay, last case. So, mini implants is just one of the tools. And the more tools you have, the more options you can provide, the more people you can serve. Obviously, we still do conventional implants. I like these implants a lot. They're very aggressive. You've got aggressive threads all the way to the top. And I like to have good initial stability. If I could torque an implant to 80 newtons, I will. And I prefer it that way. She's got a very, very thin bridge. It's a 60-year-old lady. She says she doesn't have diabetes, but she's pretty overweight, so I'm wondering, there may be underlying diabetes there. So that's what we did. Let me show you why. That's why. Look at that bridge. Now, we have options here. We could have done the ridge split. We could have put a block graft. And those are all options that I discuss with my patients. And I sit her down and tell her, Mrs. Smith, we have some options here. We could do bone grafting. We could do a ridge split. We could wait 6 months. Then we could try to put the implants in. We wait another 6 months. And then we'll put the crowns on. And this is what I have to charge you. We have another option. I could use thinner implants, and that could get you finished in 6 weeks. And of course the question is, well, are they strong enough? Are they going to last? I tell her, all the studies show over the past 15 years, the success rate is exactly the same. I think I could do a pretty good job for you, and I think you'll be happy. At this point, she trusts me. We had good success with the upper implants. That's what we do. We carefully navigate the bone with bone sounding, making sure we don't perf. These implants, some of them are 3.0 millimeters, some of them are 2.5 millimeters in diameter, some of them are 12 millimeters long, some of them are 10 millimeters long. I work with what I have with. We create a custom treatment for the patient. Instead of customizing the bone to fit our implants, why do we have custom implants to fit the patient? Doesn't that make more sense? Instead of just growing bone, trying to grow bone, sometimes doesn't work, very difficult to do in big defects, and then having the failure, having to redo the bone grafts. It's an endless process. People go through for years and still end up with a denture. I like what Dr. Linko had to say. He's one of the pioneers of dental implants. And if you're doing dental implants, you really should know, study up the history a little bit. Look at guys like Norman Cranen, Lenny Linko, and others, David Bezos up in Canada. See what they did, and there is something to learn. Not everything has to be the same 4 or 5 millimeter screw. And Dr. Linko said, to continually treat implant for bone augmentation, to create an arena for placement for root form implants, rather than place a properly designed implant to fit the unusual or abnormal bone situation, is way out of line. And of course, he's talking about saperiosteel and blade implants. But again, this is not that different from a blade implant. The philosophy is the same. They're using a thin implant to compensate where you have very little bone. So that's the framework. We just tried it in last week. It fit fine. Thank you for your time. Thank you for listening. And thank you for having me here. I appreciate it.
It's early in the morning. I'm laughing at the sun. My mirror